I'm Dr. G, and we're here with Engaging Minds. Every week, we like to look at the issues we're facing from a deeper and more psychological point of view. And one of the issues that I know everybody is facing, whether it's personally, professionally, or someone you love, is the war on drugs. And I like to call it the failed war on drugs. And one of the reasons I think it's failed as a clinical psychologist has to do with the language that we use. We call it a war on drugs, but actually what we need to be calling it is an understanding and developing deeper insight into drug use, both, if it's something that we're dealing with on a personal level or a loved one. And that's what inspired me to do this show, because I know there's so many people out there, our audience members, that are dealing with this issue. And if you tune in right now, you're going to get 4 experts who are going to help us dig a little deeper and understand what this war is really about and give us some practical insights on how we can maybe in our own little way turn it around. So with that, I'm going to welcome my guests to the show. And as I said, they're all experts in the world of drug rehabilitation. We have Stephen Cohen Enrique, who is a recovery coach, and he also started a program called Parallax Solution. And we have Dr. Damon Raskin. He's an addiction specialist out here in Los Angeles. We have Shannon Jones. She's an RN and co-founder of Grace Premier. It's a concierge nursing company. And we have Dr. Sam Snodgrass, who is on the board, who is a board member and board director of Broken No More, which is a nonprofit organization that deals with drug and alcohol abuse. So with that, I want to welcome all my guests to the show. It's a pleasure to have you on.
Thank you.
Thank you for having me.
And I'm going to start with, thank you, Sam. And I'm going to start with Dr. Raskin, and since he's our medical specialist, yes, I'm going to ask him to talk to us about this. I want to really focus on the opiate crisis for now, because this is something that we're reading a lot about. We're trying to understand it. So in your opinion, what are some of the best treatments available from a medical standpoint when someone's dealing with an opiate issue?
Well, again, I like to customize the treatment for the patient. If we're talking about opiate dependence, there are medical assisted treatments. So patients can sometimes get these treatments in a rehab center, sometimes in their own home. They can use our service, as you know,
as Concierge Detox, our personalized service.
But medications can help take away cravings, but medicine is not necessarily the answer. There are medicines that can block opiate receptors. There are medicines that can act as partial substitutes so that patients can get off of the opiates. But nothing is a substitute for a comprehensive program which involves psychotherapy, really to get to the inside of why patients are using opiates as sort of a self-medication for trauma relief or for their depression or anxiety issues. So it's a combination of medicine together with a psychotherapy, which really helps the patient the most, but you really have to want that.
Yeah, no, I couldn't agree with that more. And one of the things when I'm seeing patients is once we get the addiction crisis sort of under control, we really have to look at the deeper psychological issues, the stuff that got you into the problem in the first place. If
Absolutely.
You can find a way to process through that, then you're going to find a way to maybe get some longevity.
And we have to change our mindset, because you're talking about a war on drugs or a war on opiates. It's not really that.
It's not a war.
No.
I mean, we have to get an understanding of it.
And it also can't be a criminal thing. That's the thing, is people think that this is such a, it's a criminal behavior. It's not. It's actually a disease. I see it as a disease, like patients with high blood pressure or like diabetes. They have opiate use disorder. That's what we call it now. It's an opiate use disorder. And we have to treat that as a medical condition, really.
So that's one thing I want our audience to hear. One of the first things is that this isn't a criminal offense. This is something that is an illness, a disease, and you have to look at it that way. Sam, I'm going to break to you because I know you've had some personal, professional insight into this. I'm wondering what your opinion is.
Okay, first of all, it's not a war on drugs. It's been a war on people who use drugs.
Great distinction.
Yes. One of the things that happens is we tend to forget that the people who use drugs are just that. They're people. And I'm going to agree and disagree a little bit on the treatment options. Medication-assisted treatment with methadone and buprenorphine is the only effective treatments for this disorder. the psychotherapy aspect of this has not been shown to improve the effectiveness of the medications. There's a reason for this. This is a disorder of brain structure and function. And the medications themselves are what stabilize brain function. And therefore, the person, once the brain function is stabilized, are then able to go on and live the life they were supposed to live.
So you're advocating that I'm just trying to understand, because we want different points of view here. It's a brain disorder? Is that what you're saying?
It's an acquired disease of brain structure and function.
Oh, okay. Okay. And so what is you're just saying that there's methadone treatment, and then what happens after that?
There's methadone treatment. This is a lifelong condition. This is not something that is cured after somebody's on methadone or buprenorphine for 6 months. They get off of it. They go through counseling. They go through psychotherapy, and they're fine. I wish it was.
Okay. I think that's what's so great about this show, is that we have different. I've definitely had a different experience with it.
Different views on this one. We are.
What?
The data shows, all the studies show this, that counseling and psychotherapy add nothing to the medications. And this has been shown after research study after research study.
Well, I'm gonna politely disagree with you, because I've had personal experiences where I think it's different.
Yes.
But that's what this show is all about. I'd actually like to hear other people's opinions too. So I'm going to go to Stephen. What's your thought about what Dr. Snodgrass is saying?
Thank you, Doc. I appreciate, by the way, your choice of choosing a different word than war on drugs, because I'm right with you, and language is so important, not just to me, but obviously to the patient or to the client. And coming from an alcoholic survivor is what I am, because I'm also a cancer survivor. Mm-hmm. And 1957 is when the AMA declared alcoholism a disease. And yet, still 60 years later, it is still somewhat taboo. I don't necessarily agree that it is black and white, where you can have a chemical-dependent or medically assisted treatment that's going to resolve all issues, because I look at it as each person is chemically built differently. So alcohol is the same amount of alcohol that I would consume versus you is going to affect me differently than it is going to affect you. And the same thing I think with medication. For me, my leukemia treatment is going to be very different than somebody else, even though we may have the exact same disease.
So I'm curious, Shannon, what are your thoughts around this? And as a nurse, a professional nurse, I know you've worked a lot in the detox area. So if someone came to you and wanted to go through a detox program, what would you do, and how would you address some of these issues?
Well, we have had clients go through concierge for detox. It's a multifaceted approach. You need both medication-assisted, but you also need psychosocial and somewhat of a team approach to it. Many of the clients, you want to first start with what cause. So a lot of that is psychosocial. It can be a physical ailment, or it could be something emotionally, some kind of trauma that happened in their history or in their past that kind of got them to begin to get onto drugs and use it as a way of numbing some form of a process.
Some sort of feelings. You know, I'm going to ask Dr. Raskin to address Dr. Snodgrass. I'm wondering if you have any thoughts or feelings about what he said.
I actually do respect Dr. Snodgrass and his opinion, because I think we all come from a different place, and we all see the research studies in different ways, and we all have our own clinical experiences. But my experience is that medication-assisted therapy can be very helpful, but is not necessarily the be-all and end-all. And he mentioned methadone and buprenorphine. There's also a medicine called naltrexone, which comes in an oral version as well as in a long-acting once-monthly injectable, as well as an implant. And naltrexone actually blocks opiate receptors completely so that patients can't get high on opiates. And that does work together with psychosocial therapy, and has been shown in several different studies to be helpful in preventing relapse. So I think we all need to, take a look and see what's best for the individual patient with the use disorder.
And Sam, what are your feelings about what we're saying?
Okay, number one, Vivitrol. There have been 2 studies, one in Norway and one in the United States. Both of the studies looking at Vivitrol used maximal dose of Vivitrol. The comparison to buprenorphine, they used an inadequate dose of buprenorphine. 16 milligrams is a bare minimum dose of buprenorphine that should be used. Yes, in those 2 studies, they seem to come out fairly equivalent. But again, if you're looking at measures such as retention and treatment, which is one of the major measures of clinical efficacy, the higher the dose of buprenorphine, the better you do. Also, Vivitrol has a couple of problems. Well, 2 or 3. One is that there's an increased risk of overdose with Vivitrol. If you look at the FDA,
Sam, I just want to cover. I didn't want to get into the weeds about the drugs, so we're going to talk in a little bit more general way. But I think the important thing is that you offer a point of view. I'm curious. So, again, I'm not clear. What is the treatment that you're advocating for?
The treatments I'm advocating are the only effective treatments that have been shown through research. That's methadone and buprenorphine, and that's not my opinion. That's the opinion of the World Health Organization, National Institute on Drug Abuse, American Society of Addiction Medicine, right, American Academy of Addiction Psychiatry, and so on. And again, what the data...
But you know what, I'm going to disagree with you there, because I've read studies where I've seen that psychotherapy is very effective in the treatment of opioids.
You tried one of those.
Well, I don't have the information on me right now, and that's not what this show is about.
Looked, and haven't found one. I'm sorry, go ahead.
But we're going to go on to some other things, because I think different people have different opinions, and that's what this show is about, to be able to show different opinions. So I'm wondering, when we come to alcohol use, what would you suggest as far as... I'm going to go to Stephen. What would you suggest?
Well, for myself, I had done antabuse. I had taken the Vivitrol, and when it was in its stages before it was even called Vivitrol, and didn't even know that 10, 11 years ago. And it was a triumvirate of medications. But for me, seeing a psychologist, seeing a psychiatrist, and being able to have that medical support, as well as having my own outside foundation, actually created a good structure for me to get sober and stay sober. And if I didn't have the medication, and if I didn't have the psychology grouped together, I don't think I'd still be on the planet.
And Stephen, what do you think about AA and sponsor and having that community around you that can be supportive as well?
You know, it's a fine line, because I meet a lot of clients that say, I go to so many meetings and I fall down and I don't understand it, and why is it? And for me, when I have a client like that, and I said, well, there has to be other work for you to do outside of the 7 or 12 hours that you go to meetings. And that's where the real work will come in for you. And that's where I would come in and help them out. I think AA is great. I think NA is great. I've worked with OA, just about all of the A's.
Yep.
I love that, all of these. Stephen, we're going to take a break. We'll be back right out of the commercials. If you want to call in, the number is 1-800-222-5222. And I want to talk to Shannon Jones, and I do want to announce that, first of all, Shannon, since I know you and we're friends, congratulations on your wedding coming up.
Thank you.
And now all of Los Angeles knows about it.
Thank you.
It's very exciting. So
yes, thank you very much. Yeah.
I wanted to talk to you about your opinion as to why you think the war on drugs has failed, because we're not doing so well with it.
Right. I think it's a combination of things that have happened. I think that, first of all, economics play a big role in it, right? And a lot of people are very challenged.
Do you think culture or race plays a big role into it?
Actually, I think it's non-discriminatory when it comes to that. I think we're all on an even playing field, but I think the need of pressure, whether you're a CEO executive that is trying to get something off the ground, or you are fully football player that had an injury and now your career is in the balance. And so you end up getting addicted, or you're a person on welfare and you're living in the projects, or you're coming from a urban city community. So I think the pressure of life and emotional stress, and I also think psychologically, certainly with clients that I've worked with, doctors with, where we do acute, making sure the patients safely go through detox, have expressed somewhere there was unresolved psychosocial issues, whether it's from their childhood or whether it was from an event or incident that happened in life that kind of, started them on this journey.
Some sort of trauma that started them on the journey.
So I think
and I know that's
many
an area
of those things that are coming into place, and I don't think that the structure has been set up or the support. I think it's people that, I think Doctor said it earlier, people look at it as a negative instead of looking at it as a weakness. I say, if I were to redefine it, I wouldn't call it a drug addiction. I would call it a drug weakness. It's a weakness. It's something that you're vulnerable to, that you want help, and just sometimes you can't.
Because all of us know this, I'm going to have Stephen address it because I know that his work deals a lot with trauma in the Parallax solution, but everyone I've dealt with that has had a drug problem went to drugs because they needed some help. And it's something that soothed them or made them feel better at the beginning, and then we know where that's going to lead. So most people go there for self-medication. I know Dr. Raskin has that experience too. So, Stephen, if someone would come to you, how would your program deal with it in about 1 minute?
It's the first part is the listening. And really have to understand where the person is from a psychosocial environment, and what the transparent issue is, what type of drug or alcohol or eating disorder it may be, but then working with the therapy team and the family, and also discovering, okay, there wasn't necessarily a magic button, because sometimes there is that explosion that happened at the age of 12 or 25. And that's where the psychology and the psychologist comes in and will help bring that to a surface and work through it in a healthy way, rather than the dangerous way that a lot of happens now. But
a lot of reparenting. I just went to a conference on that yesterday, and we were talking about this concept that a lot of reparenting needs to happen. And it happens right away. The moment you walk into a doctor's office, or a nurse you come in contact, or a therapist like yourself, through that transference, you're already starting that positive relationship.
The blind trust is that's where you're feeding into that, and which can be very dangerous, but also inevitably be very helpful and advantageous to the client.
So one of the things I want our audience to hear, that your relationships that you have are extremely important, and to try to find people that you can trust and build a powerful relationship with, that's an alternative to maybe some negative relationships that you had. So that's a really important marker along the way that we're going to talk about here. Dr. Raskin, so if someone comes to see you, whatever the drug issue is, what are some of the first steps that you do? I'm curious about the process.
Well, again, I agree with Stephen. First, it's about listening, and it's about hearing what they're using, and establishing an honest and open communication with the patient so that they feel that they can really open up to you and tell you everything that they're using and doing. And as far as my point of view, from a medical point of view, I want to detox them safely. So I really need to know what they're on and get some good information about that. And then I design a detox program based on what they're using, really. So oftentimes patients don't realize how dangerous it can be to sort of stop drinking suddenly. If they're drinking a bottle or two of wine a night and then they go, you know what, I think I'm going to quit, they're at risk for seizures and death. So
that's pretty intense.
Well, it's true. And so
but it's true. I'm looking at all the medical professionals.
Say it the way it is. And the same thing if patients are taking benzodiazepines, which include drugs like Valium or Xanax or Klonopin, and they're on these drugs for long periods of time and they discontinue them abruptly, again, they're at high risk for seizure. So again, these are very, very important to have a medical doctor who understands how to do this safely. So that's where I come into play.
Yeah, and that's where Shannon comes into play too. And again, another marker that we're talking about in the show, and I know Stephen will agree, is now I'm going to use a moment to to plug our work. So Dr. Raskin and I have started Concierge Detox LA, and what motivated us, in the same way I know that Shannon is motivated to do concierge nursing work and Stephen does concierge counseling work, a lot of us here felt like we needed individualized care, that each person comes to us, and there isn't a cookbook solution. That's what I want people to hear. We've got to do an intake. We've got to figure out all the complexities of what's going on, both genetically, socially, psychologically, and then put together a program. And that's what we decided to do at Concierge Detox LA. So if anyone wants that information, you can contact me at 323-935-9712. And we're also in contact with Shannon Jones and also Stephen Enrique. So we got a couple minutes left. I'm wondering what you guys think about what Dr. Raskin said about this multidiscipline approach.
For personally and professionally, it's the only way that I think can work for the immediate and the long term, because too much of what we see is acute. And, if you detox yourself, which I have done, I don't even know how many times,
right.
It's incredibly dangerous and it's life-threatening. And I can't detox myself if I go to a psychotherapist. I need medical assistance. And conversely, I can't rely on psychotherapy to be the only thing to help me through my alcoholic addiction and also through
So what we're looking for is a team approach.
It's a team approach, and again, it's individualized because not everything is 50-50. And one person is going to like scrambled eggs and the other one's going to like an omelet. And that is going to work for them versus the other choice.
So I want our audience to hear that this is very much an individualized way of looking at things, and you have to look at it from a multidimensional point of view. I was thinking about this. A friend of mine said it when I told him about the show, and he said, one of the misconceptions a lot of people have about professionals in the detox world or in the addiction world is that they think that we, quote, have it all together, have never had to struggle or had issues that we have to deal with that. One of the ongoing jokes I always use is people say, oh, you're the poster child for mental health. And I'll say, no, that's not exactly it. We learn by our own process and our own struggles. And with that, I wanted to go around to our panel and ask them about why this work, what inspired them to work in addiction, because there's so many things you could choose to do. So I'll start with Stephen. Stephen, why this?
Well, I think, just to paraphrase you, I think I'm the poster child of why mental health is so important.
Okay.
And the continued mental health for me, and years ago I kept saying, I don't have an issue, I don't have a problem, and yet changing jobs, changing houses, changing everything, income, and then I finally went to treatment. And I liked it so much, I think I went 5 or 6 times. And depending upon how you look at it, I'm batting 1,000.
Did they keep giving you discounts every time?
I was asking, and maybe I was too drunk to ask for that. But,
okay.
And for me, I did so well in treatments. And whether it was 30 or 40 days, it was the aftercare that I just stepped out and imploded. And that became my focus of what I can do and working well with people, and then obviously going to school and grad school to get more education about it. But nobody can walk out of an operation and be completely healthy and back to normal. There's physical rehabilitation, and then there's mental and emotional rehabilitation.
And I think we learn from those processes. Mm-hmm. They make us. It's an old cliche, but if it doesn't kill us, it makes us stronger. We have more resiliency, and we're able to see the world in a different and deeper way. So if a lot of times you can turn those experiences into something more positive. I'm curious, Shannon. Again, I know whether it's personal or professional, mm-hmm. sometimes it's outside stories that inspire us. Why do you love working in this field?
Well, because you actually can make a difference. First of all, going back to something that Dr. Raskin said, it's very important for us as clinicians. As the RN, we're clinically trained to help safely under the doctor's orders to help a patient at their most critical time to detox safely. And then to see the success stories. I've had many patients over the last 4.5 years throughout that would either email or call and say, hey, that was so great. This is how I'm doing now. So you hear the success stories after having that multi-team approach of dealing with it. But for me in particular, the reward to know that at a person's time when they were most vulnerable, we were able to effectively help them safely through their withdrawal process is just wonderful.
And I mean, that's
in
the
a customized
key.
program.
Yeah, and that's the key, that it's safe.
Yes.
And that's something Dr. Raskin has been advocating, that it's
Absolutely.
so important if you're going to decide to stop using a drug to get the medical supervision that you need. So Dr. Raskin, yourself, there's a lot of areas I know that you specialize in, but I know this is something special to you because we've started our own company around it.
That's
so
right.
Where's the inspiration?
Well, there's a lot, but I hark back to a patient that I had very early on, right after residency, and I started my own practice. And I think back to her. She was a 72-year-old woman, and the main issues were the family kept thinking that she had Alzheimer's disease because she'd be forgetful, she'd be stumbling, she'd be falling. In fact, she fell so hard she had a bleed on her brain, right? And so, we sent her to neurologists, we did brain MRIs, we did all kinds of blood work and all kinds of fancy tests. And in the end, I just had to learn to ask the right questions. And finally, after a few weeks of this, I figured out that she was an alcoholic. And
Interesting.
Once I figured that out and I spoke with the family, and the family was enabling a lot of this. They would not really realize that was the problem, but they would go get her a bottle of wine, and they wouldn't see her drinking, but then they would find extra bottles here and there. And,
Shannon and I are nodding because we worked on a case without mentioning it where we had a very similar
Once
experience.
I put this, and again, with these elderly patients, a lot of times people just say, oh, they're old, they're forgetful, or they have a dementia or whatnot. But once I figured out the issue and I got her into treatment, she became a whole new person. Her personality changed. The family was so grateful. And it was sort of inspiring to see that an addiction can really be, once you've treated it, can really just, change everyone's lives, the patient, the family. And it just became such a satisfying experience to me that I looked into it further. And I became board certified in addiction medicine on top of my board certification in internal medicine.
Yeah, I was laughing with Shannon, but without mentioning any details, we had a similar case because we had worked together, and you talked about the family enabling. That was so much of the experience that we had. So again, I'm talking about these markers on this show, that this is very much a complex issue that families have to be on board. And a lot of times the therapy and the treatment has to start with the family, because if the environment is toxic, it doesn't matter what we as professionals do. We send them back into a toxic environment, chances are they're going to relapse. So I'm curious what you guys think of marijuana now becoming legal in California. And, one of the sort of cliches is this going to lead to harder drugs? Are people going to become more addicted? So any thoughts and feelings from my panel? Stephen, I'm going to put you on.
That's all good. I have a few clients that have the medical marijuana card, and one of which, in my opinion, abuses the card. And for certain circumstances, he'll use it. In other circumstances that are medically approved, he'll use it. But at the same time, it is what's the volume that they're going to use it for? And I look at everything as an individual, not so much as a 10,000-foot level. And economically, the mayor of our town and everyone's rooting and whatnot, and Malibu is happy. But at the same time, I don't think it's going to make or break society. And I think that, again, if it's medically induced and medically used,
But what about recreational use? I mean, now it's legal recreationally in California.
Well, recreationally, and for me personally, I never enjoyed it other than getting through chemo. But at the same time, again, it's everything in moderation. If it's not abused, it shouldn't be that big of a problem. And now, granted, I don't have a magic 8-ball, but every drug that we have has been abused.
Right. Shannon, any thoughts or feelings? I'm curious because I actually have some thoughts and feelings. But
I actually don't think it's going to make a big change overall in the big picture, because even though it's legal, I think people were doing it anyway.
That's exactly what I feel.
If you're going to use it, they were using it. Back then they were rolling it up with grass and doing those things that may be going in a door, or something like that. I think at this point, hopefully people are more informed and educated and getting things that, as you said, for the right use, whether it's social or for medical, but I don't see it being a factor in the...
Dr. Raskin?
Well, look, I think there are pros and cons of marijuana, but the truth is that it can be addicting. I don't necessarily think it's a gateway drug, but there are studies to show that it really is a drug that can be addicting. A lot of people don't realize that. If a certain percentage of people will try it, a certain percentage, around 11% or so, will become addicted, which means when they stop, they actually go through withdrawal symptoms. They become not hungry, they have restlessness, they can't sleep, etc. But there are some benefits that we're seeing, but we have to really do more research and studies. Those studies have been inhibited by the federal government, still making this an illegal drug, a Controlled 1 substance. So we need to do more research, but it looks like there could be some strains that might be helpful for pain, for example, or for epilepsy. Recently, just last week, there was a type of CBD, which is not a THC. It's not psychoactive, but it's a component, one of the chemicals in marijuana, which has been shown to reduce seizures in a certain type of pediatric population. So there are definitely going to be some pros, and I think we have to look at some of the cons. And again, some of the cons could be addiction, but also can be personality changes or psychiatric reactions.
I agree with all three of you. My thought is, if we, as a psychologist, I'm going to deal with the emotional side of it, not necessarily the expert in the medical side or the research side of it. But if you look at the issue of addiction, that the use of the drug or the addictive part of it is really based on an emotional or psychological issues. In some ways, it doesn't matter what the drug of choice is. And like Shannon said, marijuana was just pretty accessible anyway. So why send people to jail and why spend all this money for absolutely no reason, and where, they'll probably become more of a criminal when they're in jail than because of the marijuana issue and have bigger problems. So I think we have to address the emotional issues. If we address the emotional issues in combination with the medical issue, both from a nurse's point of view and a doctor's point of view, and Stephen and I as the therapist dealing with the emotional side, then you have more of a chance of not being addicted, because I don't think it's necessarily the substance. Now, I know some people are more vulnerable to certain substances like alcohol, but again, I think we have to look at it. That's what we're talking about here, is the multidimensional approach. If you deal with the emotional side of it, chances are you have less of a chance of being addicted. That's my 2 cents. So in some ways, I'm glad that people are not going to jail for really no reason. And before the commercial, I was introducing Shannon Jones. She's one of our esteemed panelists. I'm going to have her tell you all, if you wanted to find out more information about her and her company, how you could do so.
I can be reached at shannon@gracepremier.com at my email, and my direct contact number is 562-338-6087. Love to hear from you.
Oh, that would be great. Why don't you say it one more time in case
That's
someone didn't get it.
Shannon, @gracepremier, all one word, .com, and 562-338-6087.
And why don't you explain to our audience briefly what Grace Premier is?
Grace Premier is a private concierge nursing service where we provide in-home, private, customized nursing services under physician's order. That's very important to say that. So we work in collaboration with physicians for those patients that don't want to have to stay in the hospital or are being discharged and don't want to have to put them in assisted living and want to stay in their own homes, but need to have that individualized care, whether it's 8 hours a day, 24 hours a day, and that's That's RN, LVN, and licensed care. And we are nurse ran. So myself and my partner, Veronica Johnson, and we're there to provide customized care.
That's exciting to hear, and I do want to share with our audience that you will be coming on as one of our sponsors, so I'm very excited to have that.
Absolutely.
And Stephen,
we're excited as well. Thank you.
Great. Stephen Enrique, about your work and how can people get in touch with you?
Well, you can reach me anytime at 917-549-6976. And, it's important to explain why the parallax solution came into play. And parallax basically means that you are getting a different interpretation of an object when there's actually a shift from the viewer. And that's what we try to provide, is an internal shift with the viewer. So I'm not going to tell you that a bottle of water is now going to be a vase of roses. But by the end of what I call treatment with a client is that they're not going to actually want to even desire to have the drugs or the alcohol.
So you're saying that people have to change their perceptions about certain, I want to make sure I understand, about certain experiences?
Yes, and really it's okay. It's not going to be a battle. It's not going to be a war on that. They're going to be doing most...
Yeah, we're not doing wars.
Right. But basically, so many of us have thought that 350 degrees of our lives were part of the addiction or the chaos in the life. And actually, I'm going to show them that it's only about 5 or 10%.
So we got a really strong part of ourselves that we could bring forward.
Yeah, and that's where the opening and having a different view of yourself comes into play. And boundaries are huge with everyone, and especially those in the addiction world. And I try to teach healthy boundaries and healthy self-talk, because that's what usually gets us back into trouble.
I couldn't agree with you more. And so what's the number if people wanted to get in touch with you?
It's 917-549-6976, and you can check us out on theparallaxsolution.com.
And again, I'll tell our audience, if you miss any of these numbers, you can always contact me, Dr. Howard Gluss at live.com, or my number is 323-935-9712, and I'll get you that information. And Dr. Raskin, our addiction specialist and my partner in crime, if people want to get in touch with you, how could they do so?
Sure. Well, I have a private practice in Pacific Palisades. My office phone number is 310-459-4333. That's 310-459-4333. And my email is damonraskinmd.com.
And with the time that we have, I again, thank you, Dr. Raskin, for all that information. I'm going to talk about another addiction that we didn't really touch on here, but another failure that we're having is the obesity epidemic that we're having. And to me, it reminds me a lot of the opiate epidemic that we're having, because food is rarely dealt with the concept of addiction, that there is such a concept as food addiction that people like myself and other people are starting to talk about. So I wonder, with a little bit of time that we have left, I'm going to go around. If someone came to you dealing with a food issue or an obesity issue, would you do a war with them on it, or
Absolutely.
How would you deal with it? Dr. Raskin?
Not a war. Again, now, obesity is a true medical condition, just like diabetes, just like high blood pressure.
Just like alcoholism.
Just like alcoholism. So I take that into account. And again, I focus on medication-assisted treatment along with diet and exercise, and make it a team approach. I involve nutritionists. I involve fitness trainers. I involve psychologists such as yourself. And these are the type of combination approaches, multifaceted approaches that patients with these types of conditions need. And it's interesting you say that food is a similar addiction that we're talking about, because it really is. There are the same chemicals, dopamine, that pleasure chemical that gets released in our brain that says, yes, I like that chocolate cake. And, exactly.
Yeah, exactly.
And
no one's going to say, ooh, I like that steamed broccoli.
Exactly. And there are actually medications that can help curb those cravings. So I use that along with the team approach that we talked about tonight. So I think it's very telling.
Shannon, any thoughts on that?
I 100% agree with what Dr. Raskin is saying. Actually, even though additions on it, it's something that we all struggle with, especially females, you know what I mean? I'll put it on myself, especially myself. It's something you have to work at constantly, and it does take a balanced approach.
And Stephen?
You know, I agree with both the doc and the RN. Thank you. Just professionally call you that. But it is amazing that we see food addiction and we see food allergies, and yet people are getting more cravings and stronger attachment to certain foods. And even what I just learned a couple of years ago is that for those of us who have high allergies to certain foods, we actually crave those types of foods.
You know, I work at an obesity center and I do the intakes, the Kalili Center, and I run a group for men who are struggling with obesity, and a lot of them are going for the weight loss surgery. And there's something that just happened the other day that I wanted to share, that one of the guys came in and said that you know, it was so much like an addiction. He starts off the day good and he wants to eat healthy. By about noon, he's lost it. And he has what we call trigger foods, just like someone would have certain drugs that set them off, let's say like alcohol. He knows if he has, what are the two foods you mentioned? Ice cream or peanuts. If he has any of those, he literally cannot stop himself. So what we started to do, so I had to keep him away from those foods, because that's one of the issues with people dealing with the food addiction, is they can't, quote, stop eating, where you could stop drinking. We had to be able to say to him that he had to go sober. And the minute instead of talking about dieting, when he said, I have to go into recovery over food, suddenly became easier for him. It's like he shifted the language, and that's what we're talking about tonight, is shifting the language. So if this is an issue that any of our audience is dealing with, there's tons of help out there, and maybe you have to change the way you think about it. Dr. Raskin?
No, I completely agree. You do have to change the way. And again, it's an individualized approach. So what works for someone may not work for another person. And so I like to talk to some people about moderation, and some people say, no, you can't have any of this. But for most people, it's about moderation and learning that, you know, you can have a little bit of this sometimes, once in a while, and then move forward.
Right. But there are some people, and I agree with you completely, but there's some people that, you know, if you're out there and there's certain foods that are going to take you down that dark path and you're not going to be able to control yourself, first thing you've got to do is stay away from them. So, is there any kind of, either Shannon, anyone out there, recommendation as to like food substitutes that people could use instead of some foods that are high in sugar, fat, and salt?
Well, I think high fiber foods that fill people up, will really just sort of help with some of that. And so, you know, you can fill yourself up with a lot of volume, but not necessarily a lot of calories, and feel full. And for some people, that's enough. For others, it's not.
A new concept that's out there now with a lot of nutritionists, and I know Kaiser promotes it heavily, and so do some other places, called the plate method, where you divide the plate up, where you do more, as you said, more vegetables or foods that are, you know, there, and you put your protein here and you use less carbs.
So actually
really balancing out, controlling, and taking that moderation approach.
So with the time, we're going to end the show. So I wanted to thank everyone for coming on the show. And one of the things I wanted our audience to really hear is the complexity of what we're talking about, that when you approach a drug or a food problem, whether you're dealing with obesity or an addiction, and obesity is, to me, food is a type of addiction, that you get the professional help you need. There's no shame in that. And you put together an individualized program that's going to help you both medically, psychologically, and eventually spiritually, to try to change your life. And really, you got to change your life and move into a different place with it all. And there are people out there to help you. I'm Dr. G. We'll be back next week. The number is always 1-800-222-5222.